A very interesting topic which Dr. Rajat has given me. When the patient is in front of us in advanced colorectal cancer, there are three main large scenarios what we look at. Whether it's a resectable metastatic disease, whether it is unresectable metastatic disease, or potentially resectable in future following some treatment which we give to patient. Now, why do we have to discuss this topic? We have to discuss this topic because 5FU alone, we all know, is 10 months is overall survival. When we add either irinotecan or oxaliplatin, it increases to 22 months. When we add either bevacizumab or anti-EGFR, it increases to 30 to 36. Immunotherapy Keynote 177 trial, the last reported, the median overall survival in the experimental arm has not reached. I'm waiting, in case if somebody has seen the overall survival, can put in the chat box so we can learn. It's very simple. When we talk of 10-year overall survival in rectal cancer at 85%, in advanced colorectal cancer, 3 years, 3.5 years is not good enough. And we need to improve upon that. So today's topic I have tried because, the standard biomarker-driven management we all know. So I've tried to tweak around a little bit. And please let me know if something which I say doesn't make any sense. Biomarkers currently done in day-to-day today. PANRAS, we all know KRAS alone is not enough. You have to do KRAS, NRAS, that is PANRAS. BRAF 600E, MSI high or stable, and whether HER2 is amplified or not amplified. I think all of us are doing these 4 biomarkers. And I don't think that anybody can miss any of these markers. And if they are missing, please start doing that. What can be done? What are the potentials? One, PPD enzyme deficiency. Second is PDL1 because it's easily available on immunohistochemistry. Tumor mutation burden. And this is a very interesting thing. I'll just share some slides about that. Whether upfront NGS should be done or not, which will capture NTRK, tissue agnostic for larotrectinib and entrectinib, but only 0.5% of CRC. P10, PIK3CA, we really don't know what to do with these. Any KEAP or STK11 mutations, we really again don't know what to do with those. And the last but not the least and emerging is cell-free DNA on liquid biopsy, that is on blood. I will not talk about PPD enzyme deficiency going forward, but I have discussed this point with many national and international people who are looking after GI cancers. People are not doing this routinely. But if all of you can recall, those who have done practice for 10 years and above, we have at least one case on day 7 of 5FU-based chemotherapy. Patients' neutrophil count is less than 500, and many of these patients die. So I personally think that in a medico-legal era, PPD enzyme should be discussed with each and every patient for colorectal cancer who are to be started on 5-fluorouracil-based chemotherapy. I have started doing this in almost all patients. I have yet to get the first positive, but I have not got, after starting doing that, I have not got any grade 4 myelosuppression as well. So this is something which I think everybody should keep looking at that. Dr. Shyam Agarwal sir always says कि अमिश तूने NCCN तो दिखाया ही नहीं. So no topic can be complete without NCCN. NCCN says these are the 4 biomarkers which are validated as of today in 2022. That is RAS, BRAF, HER2, and MMR. These are the 4 things which are sort of standardized. Question is, should we do NGS upfront? Or should we do RAS and RAF by point mutation PCR? HER2 by immunohistochemistry? MMR by immunohistochemistry? Can we miss out some of the mutations which are basically justified by giving treatment? So very quickly give one real live example. The 62-year-old male who's doctor by profession, right-sided CA colon, localized disease, post-op, there was a leak at anastomosis. The chemo was delayed by 60 days. 3 months after adjuvant chemotherapy, there was a progression at local site and liver, peritoneum. There was one nodule biopsied positive. MSI by immunohistochemistry was negative, BRAF wild type, HER2 non-amplified. What next is a question. Folfiri, within 3 months, just giving Folfox within 3 months, 5 cycles, patient progressed. Really, Folfiri will work. Daughter of the patient was a doctor at, still as a doctor at University of Pennsylvania. She had some project going on at Mass General Hospital, New York. She sent her NGS there, and there was MLH1 mutation was seen. Talked with patient daughter and patient who's a doctor. We started on nivolumab. 2 days back, just 2 days back, patient completed 22 months of IO. 4 CT scans every 6 monthly, all in complete remission. My question is there a biomarker driven or NGS driven management? I don't know, but whether should we do upfront NGS in all metastatic patients is a question which we don't know. Since we are talking of MSI high, I thought let me complete that chapter of biomarkers. First line treatment in deficient MMR or MSI high, nivolumab plus ipilimumab or pembrolizumab alone is approved. You can use it as the first line in unresectable synchronous liver or lung metastasis only. This is based on Keynote 177. As I mentioned, there was a huge gap in the PFS and OS has not reached in the experimental arm. But remember, not all patients of MSI high respond. And you see the circle which is there in almost every IO treatment. There are some patients who are rapid progressors on immunotherapy, and we may lose these patients very fast. So let's look at these based on biomarker results. Assuming patient is MSI high, but BRAF is mutated and RAS is wild. Will the immunotherapy work? If MSI is high, BRAF is wild type, but RAS is mutant, will immunotherapy work? We do not have the clear-cut answer, but the first scenario with BRAF, it still says it will work, while if the RAS mutation is there, probably immunotherapy will not work. Data is still not mature, but these biomarkers are here to stay. Again, MSI high. Patient has MSI high by IHC. And person like me would love to dig into it details, and I would do tumor mutation burden. And TMB is either comes low or high. Will my choice of immunotherapy change? And let's look at this interesting data. There were 3, again, retrospective data. 22 patients in one study, 90 patients in another study, and 40 patients in another study. Very, very small number of data. But look at the TMB cutoff, what they have used, either 37 or 26 or 10. But the important point is look at the TMB low versus TMB high when treated with immunotherapy. The gap is so huge. And I really wonder that I have treated many patients of MSI high with colorectal cancer, and they all have done well so far. Unfortunately, I have not looked at TMB in these patients. I would like to go back and look at the TMB in these patients, whether they were actually low or high. But there is a food of thought in the studies. The last on MSI high, potentially resectable colon cancer with synchronous metastasis, MSI high on IHC. Will you give neoadjuvant IO? Again, approved. Yes, of course. Why not? Because you can give neoadjuvant IO. You can look at the conversion rate of resectability at 2 months. And if the patient is resectable, go ahead and do the surgery. This is a very, very interesting paper in 2022 West Oncology Conference. And I came across this paper. It's very, very interesting. There were 14 patients of MSI high who were treated with IO or IO plus IO combination. 13 out of 14 had radiologically persistent disease. But when these patients, all 14s were resected, 13 out of 14 patients had PAC CR. And one patient who had not PAC CR, only 1% tumor was positive. So the question is that could surgery be avoided in these patients in advanced MSI high colorectal cancer? This is an amazing data for me, especially to see many of these patients were labeled at Lynch syndrome. So that is a separate discussion. So to conclude on MSI high biomarker in the management of advanced colorectal cancer, You can't miss looking for MSI. Whatever method you want to do, but please, please, please look out for MSI. IO is approved in first line in MSI high. Concomitant BRAF and RAS mutations also very, very important. And you have to keep looking at the data to see whether one does not respond to IO and other response, or both do not respond to IO. NACT setting in limited Mets disease, IO can be a safer option, or in future, there may not be any surgery. Patients can have a long-term control. So keep looking for these spaces. Very quickly about the other biomarker mutations, and do let me know when I have 3 to 4 minutes left so I can conclude my topic. RAS mutations. It is always included in colon panel. Point mutations can be identified by PCR or NGS. Extremely important to look for K and NRAS both. One should not give cetuximab or panitumumab if these mutations are present. I am very sure 100% of medical oncologists in India follow this. But on the other side, this is somewhere some gap I have seen amongst the MO community. One should not miss anti-EGFR if there is a left-sided tumor and if the RAS is wild type. And this is based on the data which we all know: RAS wild type, left-sided, metastatic colorectal tumor, cetuximab given first, followed by BEV, highest survival ever seen. And we should not miss this opportunity. This is something which I wanted to say. Now, again, RAS if there are double mutations. If there's a RAS wild type, but HER2/neu is overexpressed, what will you do? If the RAS is wild type, but BRAF is mutated, will you give anti-EGFR? In both the cases, I would say trade with caution. In the first case scenario, if the HER2 is overexpressed, it will not allow anti-EGFR to work. And if BRAF is mutated, we all know that you have to trade anti-EGFR with caution. This is what I'm talking of the data in the first line. So RAS biomarker in management of advanced colorectal cancer, we have a standardized test for RAS mutations. You don't have to worry about that. If RAS is wild type, but BRAF is also wild type, and tumor is on the left side, highest OS with anti-EGFR plus chemotherapy. If BRAF is mutated or HER2 is amplified, bevacizumab may be a better initial option. So BRAF V600E mutation present in 5 to 7% of MCRC. Chemo doesn't work well. Anti-EGFR doesn't work well. So we all know Beacon study has been touted as practice changing, but look at the PFS, or 4.5, 4.3 months, and overall survival of 9.3 months. Of course, much, much better than the control arm of chemotherapy, OS of 5.9 months and PFS of 1.5 months. But at least Beacon said that target BRAF and continue giving anti-EGFR, you may get a better result. But this is a biomarker-driven talk. So there are further molecular subclassifications. People try to subclassify this group in CMS1 and non-CMS1. To that, again, very interesting in vitro study. This is called as adaptive mutability. You have BRAF mutation, you have MSS, metastatic CRC. You prime the tumor cells with BRAF plus EGFR inhibition, and alas, what you see, increased expression of PD-L1 in the tumor. So this is an in vitro study. Does it justify in the in vivo? Again, a small study where encorafenib, cetuximab, and nivolumab was given to 22 patients. If you see, and you see the response, the disease control rate was 96%. And as compared to 9.5 months of overall survival in these 22 patients, the overall survival reached almost 17 to 18 months. Again, this is just a thought-provoking thing, that the way lenvatinib and pembrolizumab is approved in pMMR in endometrial cancer, I think here also we will reach a stage where we can overcome the BRAF-associated resistance to the existing treatment. The second last point of my talk, cell-free DNA in cancer. Where are we? There are no clear-cut guidelines even today. ESMO also says more data is required. NCCN also says that at this point of time, they will not approve this. But GIASCO this year had a very interesting thing. Alexei, this was the trial by Japan and presented in GIASCO this year. And they found, sorry, this was 1,040 patients, stage 1 to stage 4. And they clear-cut showed that ctDNA negative to very well compared to ctDNA positive in terms of DFS months after surgery. Very, very interesting data. Also, one of the important point about cell-free DNA positivity, that if you give chemo in a metastatic disease, say for example, oxaliplatin or 5-fluorouracil, and if your cfDNA continues to remain positive, are you increasing the resistance to the further and further, and are you modulating tumor microenvironment? Again, a very interesting thought process. My last part of my talk is HER2/neu amplification. There is still no data regarding first-line treatment in fit patients for chemotherapy. In unfit patients, or if the patient does not want chemotherapy, yes, of course it is there. But remember, in NGS, if you have less than 8 copies of amplification, there is a clear-cut data. This may not be a driver mutation, and you may want to avoid anti-HER2. This is what the NCCN says, intensive therapy not recommended, and this is there. But from the second line onwards, all sorts of HER2, including Destiny CRC trial is there, and you can use that for your patients. So the last to conclude, MCRC has evolved a lot in biomarker space. NGS, if patient can afford, should be done either upfront or from rapidly progressing metastasis on progression. You cannot decide your treatment based on the first NGS when the patient has already received 2 lines of treatment and you are deciding the third line based on first NGS. No, that will not work. RAS wild type, RAF wild type, left side, anti-EGFR plus chemotherapy should be the option. RAS wild type, but RAF mutation and left side, encorafenib plus cetuximab can be the option. Keep looking out for IO addition. Right-sided tumor in RAF mutation, try to use bevacizumab plus FOLFIRINOX if the patient is fit. MSI high, IO or IO plus IO, irrespective of the left and right side. MSI high but RAS mutation, try to avoid IO. MSI high but RAF mutation, you can consider IO. HER2/neu amplified, more than 8 copies. Remember, anti-HER2/neu can be considered from second line onwards, and first line if the patient is not fit or waiting for chemo. And cfDNA is a very interesting space, and we have to keep looking out for more data. With that, thank you, Dr. Bajaj, for giving me this opportunity. It was really an enjoyable experience.